You can clear, everybody has to clear their.
This meeting is being recorded.
There you go. And Jessica, you good? Are you able to share your slides?
I am trying to. For some reason, my share screen button's not working. So, Jean, if I send this to you,
Yeah, I can do that.
Screen for some reason.
I have it up. I can do it if you want.
Okay.
I just made you a co-host too, Jessica. So
maybe that's why I'm not allowed to.
and I'll give it a whirl. Dr. Wade, you can go ahead and get us started.
Absolutely. So good evening, everyone. My name is Chakoti Wheat. I am the current serving president of the Maryland Dermatologic Society. Jean Ransom, who is the MedKai CEO, asked me to welcome you to the meeting tonight. So thank you for attending. I just want us to understand that tonight's discussion will be based on value-based Medicare incentive program for Maryland dermatologists. I'd like to thank MedKai, the Health Services Cost Review Commission, CRISP, Chesapeake Regional Information System for our patients, for scheduling this meeting. So this past winter, MedKai hosted the President's Roundtable meeting for leadership from Maryland specialty societies. And excuse me here. Oh, my screen just froze, hopefully.
We can still hear you, Dr. Wheat, just fine.
All right. Can you hear me?
Yeah, we can hear you fine, Dr.
All
Wheat.
right, sorry about that. This past winter, MedKai hosted the President's Roundtable meeting for leadership from the Maryland specialty societies and MedKai's component societies to discuss the then upcoming 2022 Maryland General Assembly session. And it was at this meeting that Jean Ransom discussed the value-based Medicare incentive program called EQIP, created for gastroenterologists, cardiologists, orthopedics, and neurosurgeons. He offered to talk to other specialties who are interested in the program. I spoke to Jean about my interest in creating a similar program for Maryland dermatologists, and that is what brings us here tonight. This is an informational meeting discussing EQIP. I'm very interested in learning about the potential of this program and what it means to Maryland dermatologists. Thank you, Jean.
Thank you. And Dr. We really appreciate your willingness to call this together and ask the other docs to come on. This program, which was really a partnership with the Maryland Health Services Cost Review Commission, CMMI, CRISP, and MedKai, really has been successful in its launch this year for the three specialties it's in, because physicians have really helped us kind of develop it. And I think you're going to be really interested in hearing about the opportunity tonight. We have two really good speakers, Will Daniels with the Health Services Cost Review Commission, and Jessica with CRISP. CRISP does all the quality reporting and is the kind of the keeper of the help desk, for lack of a better term, for the episode quality improvement program. So I'm going to go ahead and turn it over to our first speaker. And I think tonight that's you, Will, right? Or is Jessica first?
I'll just quickly introduce myself and then turn it over to Jessica.
Okay.
So my name is Will Daniel. I work for the Health Services Cost Review Commission, as Jean mentioned. My job is basically to create alternative payment arrangements to traditional Medicare fee-for-service as part of a statewide demonstration program, the Total Cost of Care model, that the state has been running since 2018. This model started a long time ago with hospital rate setting, and has progressively evolved towards first hospital-based global budgets, and then secondly towards a statewide program to try and reduce the total cost of care for Medicare services. I think we started due to our history with hospitals and building a hospital global budget. The principle there being that we want to incentivize hospitals to keep people healthy instead of keeping them in the hospital as frequently as possible in order to increase reimbursements under fee-for-service. That model, I think, has been very successful, but one of the difficulties that we encountered in implementation is that hospitals, when you think about them, are just buildings and they don't actually do anything. It's doctors who actually do things. And so we've been spending the last couple of years trying to build models that align physician incentives with the hospital program, the total cost of care model in general. What EQIP is, and Jessica is going to talk about this more in a minute, is a bundled payment program that tries to create incentives for physicians such as yourselves to manage the total cost of care, complications, et cetera, of an episode of care as part of our sort of collective mission in the state of providing more efficient care for Medicare beneficiaries. So with that, I'll turn it over to Jessica.
Okay, thanks, Will. And just making sure you all can see the, I guess, the PowerPoint and not my presenter view, right? Hopefully.
You're looking good, Jessica.
Okay, good, taking sense, that's a good thing. Okay, so as Will mentioned, today we're gonna go over from a high level sort of purpose and background of EQIP, then we'll dive into the policy and methodology and talk a little bit about timeline and next steps and what that means for you all. Please feel free to ask questions as we're going, put it in the chat. I guess I'll lean on Will and Jean to stop me since I can't really see the chat while I'm presenting, but feel free to just ask questions as we go along. Okay, so let's dive into EQIP. So as Will kind of gave the background, it's under Maryland's total cost of care model. The priority is reducing costs and improving quality in both hospital and non-hospital settings. Historically, with some other, especially national programs, Maryland physicians have been ineligible to participate in some of these value-based programs. And this is why a couple years ago, the state really went out with the goal of creating their own program targeted at our specialists. And that's where we got EQIP, which is really the first specialist focused program designed around achieving cost reduction and quality improvement. And again, both in and outside of a hospital-based setting. So EQIP sort of has 4 key features that we'll emphasize during today's presentation. The first and probably the most important is that this was created and the foundation of this program is physician focused. Physicians will be able to own and monitor the performance in the program.
And
second,
I don't mean to interrupt you. I just want to make sure, Jean, are you seeing Jessica's screen or my screen?
I can't tell. Oh, we're viewing Will's screen, your screen right now.
Okay. Sorry, Jessica, do you want to prompt me or do you want to share yourself?
Oh, mine says you're sharing. You're not. Okay, let me see. Can you stop sharing, Will, and I can share mine?
There we go. Now I think we're working.
Okay, sorry about that.
Oh no, it's okay. Let's try this again.
Go ahead and share. There you go.
All good?
Yep.
Okay, perfect. So here are our four main features. So that first bubble on the left there, that physician ownership of performance. The second is that we designed this program to be upside risk. There is some DIS savings accountability. However, since it's the first program of its kind, it really was designed to be very attractive to join and allow physicians to get familiarized to this type of value-based program. This third bubble talks about how EQIP was designed to be aligned with Care First episode payment program. So EQIP does have a similar design and approach, and our hope is to reduce that administrative burden across the different programs that physicians may be participating in. And finally, EQIP does give participants the opportunity to take part in an AAPM model where physicians can be potentially eligible for a bonus if they qualify and meet savings goals. So the underlying methodology, and this is the part of alignment that we are with Care First, is using the Prometheus episode grouper approach. And we'll go into much more detail in this later in the presentation. And just as an FYI, for the first performance year, which is this current calendar year, so it's ongoing, the 3 specialty areas were GI/general surgery, ortho neurosurgery, and cardiology. And we're of course talk about opportunities for episodes being added to the next year. Now to take a step back, so when we say that EQIP is a value-based program, a value-based payment model, there are three main outcomes that define better value and really what we hope EQIP achieves. Did my thing just die? Strange. Can you guys still see my PowerPoint?
Can't see the PowerPoint, I
No.
think.
Okay, it just totally quit on me.
There we go.
Try it again.
We're falling apart tonight.
I
We're usually
know.
much smoother than this.
Where was I talking? Here we go. So EQIP really hopes to either increase quality while we're keeping costs at the same, or improve quality while or keeping quality the same while decreasing cost, or in this ideal state, which again we hope EQIP really does align with, is increase quality and decrease cost. That would be the best goal that we could have. So when it comes to value-based payments, the EQIP program is a bundled payment program. Across the nation, bundled payments have proven effective to help control costs and improve quality. CMS has shown a 4 to 6% reduction in their existing bundled payment programs, which is why we designed EQIP in such a manner. There are three primary elements of the EQIP program. First, each physician basically agrees to participate in this episode-based payment. They will be assigned a baseline period, and costs for that will be calculated to identify an appropriate target price. The target price is then used to assess the performance, and then performance year costs are compared to that set target price to identify if savings were achieved, and thus if participants are eligible for incentives. So the idea is to have this straightforward program, so again, physicians can monitor the performance and track success. Going back to that Care First alignment, let's talk about that a little bit more. So what the multi-payer alignment means is that the HSCRC and Care First work closely to align their episode program definitions so that the Care First program, which is called the Episode of Care program, and the EQIP program have parallel incentives and design elements. Again, the goal was to make this program easier for our physicians. Therefore, at the fundamental level, the Prometheus episode grouper was used to design both programs. However, EQIP does have separate incentive and policy decisions, but again, that core principles and design are very similar across the two. And we wanted to give the opportunity to create rewards both for Medicare and commercial programming. I think I see a bubble in the chat. Okay, that was just Jean. Okay, so now let's walk through the element designs of the program. So with many policies, it's not a surprise that you're going to hear a lot of acronyms. So we wanted to start with some definitions up front. So first, you will hear a reference to a CRP entity. And this is essentially a Maryland hospital that each physician signs a standard contract or agreement with to indicate that they would like to participate. Again, we'll chat through this element more, but basically that CRP entity is what the state is using as an administrative function to be able to pay out the incentive payments to participants. Moving to the next item, EQIP entity is the main participation function of the program. So an EQIP entity can be an individual physician or care partner, or it can be multiple care partners or physicians. So for example, this can be a provider practice. It could be two practices grouped together or a subset of a practice. Really, it is any grouping a physician would like to participate in as an aggregate. An important point here is that the EQIP entity is the level in which we will assess performance evaluation, again, at that aggregate level. So additionally, entities will receive one lump sum incentive payment based off of the aggregate performance at the EQIP entity, regardless of how many participants they have in that entity. Next, we get to care partner. So that's essentially what we were calling our specialty physician. So these are the people who are actually practicing the medicine and performing the care interventions. each care partner is required to sign that standardized agreement with the CRP entity. And again, care partners continue to receive their normal fee-for-service payments from Medicare. Just as by participating in EQIP, they have a potential for that incentive payment on top of your typical billing processes. And as a reminder, of course, those care partners are eligible to achieve quality payment program status and potentially have that bonus opportunity as well. So finally, you have HSCRC and CRISP. And so we are the main policy drivers and the ones who are calculating the episode's monitoring performance and determining the incentive payments. The HSCRC and CRISP is also responsible for maintaining the reporting requirements to CMS. Again, we had a goal of having a low reporting burden for those EQIP entities and our care partners. Okay, so that CRP entity. So the one Maryland hospital taking that CRP entity role is the University of Maryland Medical Center. And by having this partnership, it's enabled EQIP to be recognized as an advanced alternative payment model with CMS. So while UMC was selected, any qualifying physician in Maryland is eligible to participate regardless of their prior or current relationship or even their privileged status at UMMC. So a physician could never have even touched any of the hospital systems and still be allowed to participate in the program. And this is because the CRP entity or UMC really has two main roles. First, they receive that list of care partners who are electing to participate, and they generate that standard contract. And second, they distribute the checks for the earned incentive payments. So no, UMC is not responsible and will not be calculating the incentive payments. Essentially, HSCRC will tell UMC what to pay each entity, and UMC would cut the check. So again, because they are siloed to that administrative role, we want to point out that UMC does not have any access to protected health information. There's no data sharing agreements that need to happen between the individual physicians and UMC. And ultimately, they also do not have any access to performance analytics, and again, are strictly quarantined to those administrative functions that we just discussed. And again, to point out the policy decisions and the support really comes through HSCRC and CRISP. So let's dive into the requirements for the participation. And there's sort of three main areas. So first, for physicians to qualify as a care partner, it means that they need to be up to date in the PICO system. This can be a crucial, or this is a crucial piece in the CMS vetting process. And it can be something that is easily overlooked and is a reason why care partners would not be able to participate in that year. Additionally, we require that care partners use CERT or EHR and CRISP, the Health Information Exchange. So in that second bucket is the enrollment requirement, which really begins with the definition of that EQIP entity. So physicians or care partners must determine if they are signaling that they would like to enroll in an EQIP entity as an individual or with multiple care partners. From there, an entity, so again, as an aggregate, that entity will select the episodes and interventions and all agree to the quality metrics that they would like to participate in. From there, each individual care partner signs a care partner arrangement or that standard contract with UMC. And finally, again, as an aggregate, the entity will determine where the payment incentive will be set. As a reminder, the payment is sent to one single source across all the care partners in an EQIP entity. Now, this final participation requirement, this green box, talks about the episode thresholds. So thresholds are determined based off of Maryland Medicare beneficiaries. And again, the threshold is at the aggregate level. So for a single episode, we require a minimum of at least 11 episodes in the baseline period. So for one singular episode, again, across the entity, so whether that be one physician or 10 physicians, that entity must have at least 11 episodes in the baseline, which is calendar year 2019, across all of their care partners. Now, in totality, of all the episodes that are selected, the EQIP entity must have at least 50 total episodes in the baseline. So a simple example could be if an entity selects 4 different episodes, each of those 4 episodes must have a count of at least 11, and then adding the quantity of all 4 of those episodes together, there must be at least 50 episodes in baseline. Okay, so now let's talk a little bit about intervention selection. So an EQIP entity must select what interventions and performance improvement opportunities they will implement to achieve the program goals of improved quality and cost reduction. So they can implement a range of activities, and typically that falls under 3 major categories. The first is clinical care and care redesign, and that can mean implementing new evidence-based protocols in their practice, for example, discharge planning, or setting a standardized process for provider follow-up. The second is beneficiary caregiver engagement. And this is all about implementing increased shared decision-making. So this could be education for some of our surgery-based ones. It could be education pre-surgical. It could be an in-home assessment to address barriers and make referrals as needed. And then this last category is care coordination and care transitions. So this could be a care manager that is assigned a subset of a population. It could also be an interdisciplinary team that reviews charts to discuss the patient's needs and progress. And finally, sort of in that care coordination, care transitions, we do want to point out that the EQIP program is a site-neutral program. So selection of the site is the most cost-effective and high-quality way to improve your performance. So this could mean shifting from a more expensive hospital-based unit to a outpatient unit or ASC, if applicable, to help manage the patients, ensuring that it is appropriate and it is appropriate due to their acuity and does obviously save some cost on that as well. Okay. So here we don't need to go in detail, but these are the 15 episodes that are currently going on for performance year 1. And we'll dive right into performance year 2. So here are the new episodes. These are all Prometheus-based episodes that are being proposed or are going forward for performance year 2. You'll note that the specialty name is indicated on the left. This is sort of the closest alignment that especially us as non-clinicians have with this, but we do want to point out that any specialist, if they meet those episode thresholds, can participate in any episode. So for example, some of these may be handled more by like an internist rather than the specialty noted here. But again, this is sort of the closest alignment that we could have here. And as a second note, again, these probably don't apply to you all, but we are also incorporating a fair amount of ED episodes for next year as well. So to dive into those 3 episodes that are, again, categorized based off of Prometheus as dermatology episodes, we have cellulitis, dermatitis, and, oh gosh, I should have probably figured out how to say all these words. Decubitus, I'm totally probably said that wrong. But anyways, I apologize. These are all what are called complication episodes, and they are triggered based off of a diagnosis. So you can sort of see the categories of the diagnosis here on the left. We do have all of the ICD-10 codes that can be provided. If you would like them, feel free to email us afterwards and we can provide that, but you get a sense of sort of how an episode is defined. And again, what is that triggering event that would say that this qualifies for an EQIP episode. So just as a note, I'm going to mention this again, we kind of assign these that are fit most closely with these specialties. However, again, these can be performed by other specialties. And moving forward, so really performance year 3 and beyond, we are happy to work with physicians to create additional episodes that are tailored to the specialty. The ED episodes, and why we shared that, is a great example of that, because there were not ED specific Prometheus episodes. Therefore, over the course of many, many months, the clinicians actually were the driving factor to create the definition of the ED episodes that will be added next year. It does take some time, so we always say the earlier the better to kind of get this conversation started so we can be mindful of sort of the timeline of these different performance years.
And I really just want to say quickly on this slide, if you don't mind, that really that we should probably change that because it says staff, but I've got to really credit the HSCRC because they've really worked with physicians on these codes and talked to them about what's been included. And remember, as Jessica said early, all this is voluntary, so you don't have to do it. You can stay in the current Medicare program and not do this. Although really there's no downside in doing it because it's voluntary, and it really shouldn't say staff selected. It should really say staff selected with input from physician groups. And not only are we doing this meeting with dermatology, we did several meetings with ophthalmology and the others as well. And we've also met with all the other specialties who are currently involved prior to launching it. And in fact, for some of the specialties, we ended up not moving forward. Like oncology, we'd like to do something, but we couldn't reach a consensus. So one of the things that's really important about this is having that public-private partnership and really working collaboratively together on it. And I just think that's an important part of this.
Yeah, Jean, absolutely. And just, you know, if that's something that people are thinking about, just sort of getting the sense of like, well, what does that involve? How does my input as a clinician, what is needed? And this is sort of the episode design requirements. So again, if there is interest in developing own episodes, what is needed is a list of ICD-10 codes, again, to identify that trigger or when an episode begins, a conversation about an attribution rule. So again, that could be pretty straightforward, the rendering provider on the claim that has that diagnosis. It could be more complex, you know, basically attributing a physician that provides the majority of the E&M codes. This would be probably more applicable to like your chronic conditions. But again, there could be a multitude of different things that we could work, really the HSCRC would work with our clinicians to determine what is the best. And then ultimately, again, a list of codes that identify which are relevant costs to the episode. So it's not every cost that is within a certain time period, it is limited to relevant costs related to the episode that was selected. So, okay. So now let's get into the meat. So some policy and methodology. I'm just gonna keep a little bit about time. So let's talk about the Prometheus model, because that's a big part, and we've kind of heard that a lot. So just as a sense, really the EQIP policy has two buckets of methodology. So the first, as we mentioned, is this Prometheus episode definition. So that's where the episodes are developed, the triggers are defined, sort of that last slide of that episode criteria. If it falls in within the Prometheus episodes, that's already been defined by that model. So the HSCRC does not dictate the policy around the episode builder, but the state does contract with a vendor that owns the Prometheus episode definitions. And the second part is the methodology is this HSCRC and CMS part. And this is where the parameters around target price, around shared savings, the quality measures, reporting, monitoring, all of that, where that takes place. And of course, the conversations and the state's policy with CMS, all of that conversation and category sort of falls into this CMS plus HSCRC bucket of the methodology. So background on Prometheus, it is an episode algorithm that has been in many phases of development since about 2006. It was recently acquired by Change Healthcare, and they are the vendor who currently owns this algorithm. One of the primary reasons for selecting Prometheus is that it promotes coordination and collaboration across the continuum of care at the provider level. So in its many years of development, it has had a goal of pinpointing what costs are actually relevant to the episode and therefore can have physician accountability for the episode. Another positive thing, it's this algorithm, is that there are currently 97 different episodes that were already developed in Prometheus. So again, for year one, we utilized 15 of those Prometheus episodes, but we were basically able to double that and add, I think it's either 13 or 14 additional episodes, Prometheus episodes for performance year two. So it gives the state the opportunity to rapidly expand offerings in future performance years. So this high-level view of how the Prometheus methodology assigns services. So if we look at this, we start off with the total cost of care to really make sure you're looking at a full view of what's happening for a population. From there, the Prometheus model looks at what costs are considered relevant to the episode. So what are those relevant diagnoses to the procedure? What are the relevant services, and how do we identify those? Typically, this is done through ICD-10 coding. From there, the relevant episode costs are split into two buckets: your typical care and your potentially avoidable complications. So within the typical care category, you have the idea of core services and other relevant services that you already are doing for your patients. So while still falling under typical care, the Prometheus methodology can potentially identify overused services and setting selection opportunities. And again, this is where potentially you could see a high opportunity for cost and quality improvement. A simple example of this could be maybe certain lab workups are being, you have a higher frequency of certain lab workups compared to the usual case across the state, or that setting of care could potentially be shifted to a lower acuity, lower cost setting. So these are insights that Prometheus pulls from all of the relevant costs and shows the opportunity for savings, as well as your potential quality improvement. So this other aspect of the Prometheus model is this idea of potentially avoidable complications. And this is when you start to look at the alignment of negative outcomes or experience for the patient with the cost of that care. So again, this goes back to the alignment of cost and quality as a core outcome of our value-based payment system. So the Prometheus episode centers around providing specialists with the relevant data for the episodes that they are accountable for, and can give them the level of detail so that they can see how their practice compares to the state. So really, the way this is done is that the episodes are triggered. Usually they're triggered by a procedure, so a CPT code and or a diagnosis code. And then the episode will have a look back and look forward period. So both of these periods are configurable based off of the episode. So a pre-trigger period typically could be a 30-day period, and that's set to capture any labs, radiology workups, etc. And that post-trigger period is essentially following that beneficiary for a set period of time to count the relevant costs. In performance year one, just from a sense of it, we have that post-trigger period ranging from, I think on the lower end at 14 days, all the way out to 180 days based off of the episodes. So again, over that time frame, both pre-trigger, trigger event, and post-triggering period, the Prometheus model combs through all the claims and aggregates them into the episode to determine what relevant episode costs there are. I think so. Chronic episodes, I don't think there's any dermatology chronic episodes, so I don't think we have to include this one. But we talked a little bit about attribution previously, and this is a slightly different attribution than we've seen with some of our other ones, and it's done with the plurality of the E&M codes rather than assigning a singular physician at the point of that triggering claim. So I'm going to just kind of pass that because I don't think it's really applicable to you guys, and I want to be mindful of our time. So let me dive into the target price and incentive payments. So this is sort of in that HSCRC CMS bucket policy. And this is where the state determines how an incentive payment or if an incentive payment should be earned. So to do this, the state sets a target price based off of the episodes from the baseline. So for our new episodes joining in performance year 2, calendar year 2019 will serve as the baseline, and we will keep calendar year 2019 as the baseline for the first 3 performance years. So each EQIP entity is assigned their own unique target price. And again, at the entity level. So if you have 10 physicians, you won't get a unique target price for each of those 10 physicians, but your EQIP entity in aggregate is assigned their unique target price. And to do this, the HSCRC will look at the weighted average cost per episode of the care partners within an entity and aggregate this to create a unique target price for the entity. So then we trend those baseline costs, since it's 2019, forward to make it comparable to this year for 2022 costs, next year 2023 costs, and it allows entities to compare their real-time target price to their real-time performance cost. We do want to note that the final target price is not, or I guess the target price is not considered truly finalized until the end of the year when the final inflation is applied, but you get a pretty good sense throughout the year. Just as a note for entities who are joining after the first year, so for people who say, oh, this 2023, I don't want to join 23, but I'll join in 2024, their baseline period is not that calendar 2019, but is the year prior to joining the program. So just to keep that in mind. And another note, it's important to mention that, again, that target price is set independent of care setting. So that means across all the different settings that within a practice. So for example, again, I think surgical procedures are the easiest way to give an example. This could be an inpatient, an outpatient hospital facility, ASC. It does not matter. There is still one singular target price. So the reason behind this is we really want the cost to follow the physician and to be measurable across all of your business. And additionally, due to the model, we know that there's a gap between inpatient and hospital-based services versus like a freestanding or ASC type of service. So we want to align incentives between physicians and hospitals so that we can shift to lower acuity procedures. We can shift lower acuity procedures to lower cost settings if appropriate, and therefore make it advantageous for both the specialist and the hospital system as a whole. Okay, so here's kind of the step-by-step for your payment. And I'll try to go through this a little bit quickly because it can get into the weeds. So at the end of the performance year, we assess the results of all of the episodes in which the EQIP entity is participating. If the aggregate across the EQIP entity in their performance period, if those costs are less than the target price, we have determined that savings have been met. So we do a check of at least 3% of savings. And the reason behind this is really just to make sure that those savings are considered statistically significant. With that check met, the savings will fall into one of 3 tiers for that shared savings. So, pardon me, using baseline data, EQIP entities are compared or ranked in the state based off of their efficiency. So this rank will give us the relative shared savings that will be paid out. You can sort of see that that sort of table, that 3-line table right below the blue box. And you'll notice that the higher cost providers are ranked in the lower tercile, and therefore a lower percentile is shared. The lower cost providers during baseline are ranked in the higher percentile with a higher shared savings. So again, if we look at this, that lowest tercile has a 50-50 split with the state for the savings that they achieve. For the middle tercile, the state will pay out more savings. And again, with the acknowledging that it is harder to create savings if you are already considered efficient compared to the state. So therefore, they receive 65% of the savings. And finally, our lowest cost providers who fall into that top tercile at the start will be paid out the largest share of the savings with an 80% shared savings model with the state. So now that we know what share of saving goes to the EQIP entity, we move on to step 3 and take into consideration the clinical quality score. So quality is, as we've mentioned, a very important component to value-based program models, payment models, but it's also there to ensure that the outcomes of the program are not only cost focused, but also focused on improving patient outcomes. So therefore, 5% of your share savings is withheld pending assessment on the quality metrics. So the performance on the quality metrics will essentially determine how much of that 5% is earned back by the entity. The last step for shared savings is to ensure that it does not exceed a cap. So this is primarily driven by CMS, but it is a stipulation that there is that the calculated payment is no more than 25% of the prior year's Part B payments. We highly doubt that that will ever happen, but we obviously do want to communicate that, but that would be a very large lump sum. But there would be a maximum amount of incentive that could be earned equal to 25% of the prior year's Part B. So once all of those steps are done, the HSCRC, again, the ones who are doing this calculation, directs the CRP entity to pay the incentive payment to that one singular remission source for the EQIP entity. So it's paid in full as the lump sum, typically towards the end of the following year. And again, we always want to note here that this is one payment to the EQIP entity, and any distribution to the individual care partners within that entity is really left to that entity and is not determined at the state level. I'll walk through a really quick example. So for example, this EQIP entity is participating in 2 episodes, episode A and episode B here. And for their baseline, the costs of those episodes are $15,000 and $10,000 respectively. For the purpose of this example, we're going to keep the calculation clean, so we're not going to include inflation. However, you know, in actual performance data, we will match the cost to the current performance year costs. So with that said, it leaves the target price at $15,000 and $10,000 per episode. So if we look at what they did throughout the year, you can see that the volume that they did throughout the performance year, so 25 episodes and 50 episodes, is multiplied by the cost of their performance year, and you get the aggregate actual performance costs of the episodes. So this is line E that you see here for both of those episodes. Now that we have that aggregate cost, we can compare it back to the target price to determine if savings were achieved. So in both of these episodes, there is savings achieved. You can see the numbers here, about $17,500 and $25,000. And then we do that check about the 3% threshold. Again, yes, in this example, they met that. And then we apply that tiered savings approach. So in this example, we put this entity in the top tercile during baseline. So therefore they are due an 80-20% split. When that 80% shared saving is applied, that's how we get down to that $34,000 as the incentive payment. Again, in this hypothetical example, we did not include the final quality adjustment as well as that 25% cap check that would typically be done. But you sort of can get a sense of how the math works behind it. So at the very beginning of this presentation, we mentioned that EQIP is designed to only have upside risk, but with that, there is dis-savings accountability incorporated into this policy. So the accountability is important to drive meaningful improvements and to keep stringent standards about the enrollment in the program. So therefore, in lieu of this downside risks, we came up with the following dis-savings accountability plan. So any EQIP entity that creates a dis-savings in a performance year is required to offset those savings in the following performance year to earn that incentive payment. So if we look at that example that I just walked through those numbers, in future years, that flow chart would also map out and include a step that would have any offset from prior performance years to determine what their final incentive payment may be. Additionally, an EQIP entity can be removed from the program if they are in the lower 2 terciles, so that 0 to 66 percentile, and there have been 2 consecutive years of just savings. So the logic here is that since EQIP is upside only and we are offering that AAPM status, we want to ensure that the providers who participate are not participating just for that opportunity, but again, are actually, making, doing initiatives to drive costs down and improve quality. So the reason we do exclude that top tercile of performance is, again, we have acknowledged that an entity that is already very efficient in the state, it might be harder for them to create savings and not uncommon for them to maybe have savings for 2 consecutive years. But again, they remain in the top tercile of performers. Okay, let's get into this AAPM model. So what this means is that the care partners who participate in the program are eligible to qualify into the quality payment program. The quality payment program benefits participants in a couple different ways. First is there is a potential for an incentive payment. And again, this incentive payment with the AAPM is an additional payment on top of the EQIP incentive payments. The QPP status also means there's exclusion from MIPS reporting and the payments adjustments there. And just as a note, the timeline for that potential incentive payments will be, again, I'm using these participants this year, but will be 2024 for care partners who are participating in this current performance year, performance year 1. So again, for performance year 2, for care partners that participate, that potential incentive payment from the QPP program wouldn't be until 2025. So again, the timing of that incentive payment is different. So just as a note there. Okay, so in our mapping of the incentive payment, we talked about the percentage of the shared savings that is withheld or sort of earned back pending your performance on your quality metrics. So when selecting metrics, the HSCRC wanted to choose measures that could be applied effectively at the physician level, and it was really important to be able to measure these off of claims to reduce any reporting burden. The second criteria is that we wanted to align with CMS and their requirements for QPP, and therefore we looked at high priority and outcome-based measures, and we do need a minimum of at least 3 measures available. Finally, the metrics that were chosen in conjunction with the HSCRC priorities, we wanted to ensure that they were not, there were not different quality episodes, different quality metrics assigned to different episodes. And this was important, again, from sort of the management of the program, but to ensure that entities could be, could create their subset of physicians in any way that they would like. So for example, it does not have to be just one specialty in an entity, it could be a mix of specialties. So the 3 measures that were selected are advanced care planning, documentation of current medication, and preventative care and screening around body mass index. And these 3 measures, again, as we mentioned, are the same regardless of the specialty or which episodes an entity chooses to participate. I'd like to highlight for each of these triggered episodes, the measures are assessed by determining if these quality measures were performed by any physician in the 365 days prior to the end of the episode. And again, we want to highlight that any physician. It does not have to be the triggering physician. It does not even have to be a physician that is participating in EQIP. Again, and this is because we would want to incentivize the coordination across the care continuum with other providers who might more frequently provide these services than some of our specialists. And a last note about the quality metrics is they are measured, again, because they're claims-based. So the appropriate CPT codes are needed to ensure that credit is due for the services that are provided. Timeline. Okay, so just as a note, so the state has worked with CRISP to sort of develop this one-stop shop, this EQIP entity portal, and that's really the venue that we're supporting our participants. It is a portal in which enrollment occurs. It is where communication about CMS vetting is. Again, contracting, of course, is signed outside of it, but again, their status and communication about the contracting is done there. And ultimately, it is also the portal in which your data lives. So your performance Your baseline and performance analytics is all there. So again, access to EAP is a requirement. Sorry, EAP is the EQIP entity portal, is a requirement for participation. So this is sort of where CRISP's own sort of credentialing comes into play, and an organization does need access to CRISP reporting services to get into that portal. And that's something that can be done now prior to enrollment if there is interest in participating. And you can email equip@crisphealth.org to get that started. So timeline. EQIP does revolve around an annual participation opportunity, and that participation window is open from July to September of the year prior to the performance year starting. So again, this July through September 2022 is that enrollment window for performance year 2 or calendar year 2023. So one of the things that we mentioned sort of here for the calendar that we mentioned previously from a timeline standpoint is again that enrollment opportunity is open prior to performance year. The performance year completes, and then because of how claims run out and the algorithm of the Prometheus model and the length of the episodes, payment distribution isn't until sort of the middle toward the end of the following calendar year. So again, if we look at this for this upcoming year, 2024 would be when, if you earn incentive payments, would be when you would expect to see it.
But you'll get your regular payments for your fee for service like you normally do. There'd be no change to that, and there's no reduction in that.
Absolutely, business as normal on that side. This is a added on top incentive payment if earned. But yes, absolutely, good note, Jean. Didn't want to scare anyone off by what I just said. So this is sort of where our timeline is right now. So we're sort of in this May to June. This is our EQIP recruitment information sessions. If people do want to get access to CRISP early, this can be done. And then EAP or the enrollment portal will open early July with a deadline of September. And we do want to note one of the main reasons for sort of that short window is we do need to submit all the NPIs through that CMS vetting. And that does require some time. And the time between enrollment closing and really the start of the performance year, we can clean up some participation if people maybe don't actually meet the episode threshold, or they're perhaps changing their grouping of their entity. That all can be sort of worked out, as well as the care partners arrangement signed. And we also do want to note, and probably an important part, is that you can withdraw within that time period. You say, let's say you enrolled during that July to September, you signaled that you wanted to do this, but based off of more information, you said, oh no, this is not something I want. You're not locked in at all. But we can't add any new providers outside of that July to September period. So again, really important if there is interest to really get into that enrollment window, and there is still some more time to make some final decisions before you sign that care partner agreement, and that performance year starts January 1st of the following year. Okay, so if you'd like to schedule sort of a one-on-one demo, we can do these similar type of meetings with your organization, walk through specific opportunities, again, discuss episode definitions. Again, we can send you those triggering ICD-10 codes, things like that. We also have a monthly EQIP subgroup, and I apologize not update this slide, but our next subgroup is actually not meeting until July, but Jean and MedCai can direct you to that. But really, we always say, any questions, please go to equip@crisphealth.org. I'm typically the person behind that, and I will direct it to whoever is needed, whether it be a policy question in the HSCRC or something with our partners at MedCai. And I do want to point out that the HSCRC does have a website, but also MedCai really has a plethora of information. Prior meetings have been all recorded there. The slides and presentation materials are all there. So please use that as resources. And again, just as a reminder, that July to September date is really important. And then again, we have some contracting and finalization of episode selection towards the end of this year with a January 1st start to performance year 2. Whew. I think I fit that through an hour. So I think that's my last slide. But really we want to open it up to questions. It's probably a new model to a lot of people, except this is sort of a high level overview of the policy and the methodology and a little bit of the background.
So any questions or concerns? Any questions about the 2 codes that are being considered for the program?
Go back to that.
For dermatology?
I have some comments. This is Dr. Elizabeth Richard. Well, I think the codes you've chosen are a little short-sighted. Nothing, you said, oh, well, we're not doing anything chronic in dermatology. Dermatology, the nature of what we do is primarily treating chronic skin conditions. So I think these are poor choices of codes, in my opinion. And the other thing, I looked up what you need. You said you need to have access to CRISP reporting services. But for those of us who are in small practices, at least according to what's listed on the CRISP website, we can't get that because we're not necessarily part of a hospital system or one of these care organizations. So this doesn't seem like either both from a dermatology perspective, the measures you've chosen, and then the required access is feasible for us, unless I'm missing something.
Well, so Dr. Richard, let's start with the second question first. So anybody, any physician in Maryland can access CRISP for free. In fact, MedChi has 3 employees who are under contract with CRISP who will go out to your office and help you sign up. So that is not a problem. And if you want to have access to CRISP, and frankly, there are a lot of other things unrelated to EQIP that you can do with CRISP. You can get encounter alerts on your patients. There are all these great tools in there that can be very helpful if you're entering into these this type of value-based contracting, or just frankly some of the other stuff you might want to do. So we'd love to have somebody go out and help you out, and maybe Russ can connect you with one of the CRISP people to see if that's something you're interested in doing. So it's not a big deal, and we can help you get set up with that. And there's no cost too, which is really nice. In other states, there are significant costs for joining the HIE. The second thing on the codes is, Dr. Richard, I'd love to hear what codes you think we should include. I think the thought was when these were picked, they were bundles that were measurable and easy to use, and maybe Will can expound on that. But maybe could you tell us what you think would be good codes for us to include maybe in a future year, or maybe you can give us some ideas?
Anything chronic? I mean, I assume when you mean dermatitis, you're thinking poison ivy. I mean, everything here is basically, you don't have skin cancer, anything related to psoriasis. So those are 2 gigantic categories, which are chronic ongoing issues, which you don't have. I mean,
right.
9:30, my brain is shutting down at this point, but I'm just telling you, and I'm sure other people can comment as to other chronic conditions. But to me, this is decubitus ulcers don't really walk into dermatology outpatient practices very often, in my experience, and cellulitis walks into the ER much more than and urgent care more than it walks into a dermatology office. So.
Right. So I think it's a good comment. I think there's sort of a good news, bad news answer. The good news is these are only the ones that we have immediately off the shelf. And so, we contracted with the Prometheus episode grouper, which is fairly well known. I think their focus is not specifically in dermatitis. So I think they have more episodes in other areas. And these were the ones that were available in this specialty. That being said, we will develop literally any episode in any specialty practice, but we will need your help to do so. We're not clinicians, and your expertise, I think, is going to be invaluable for us to be able to do that. So we did work very closely with a bunch of ED physicians, and we built 20 different episodes that those ED physicians were interested in doing. And so if there are chronic conditions that you think you can manage and create episode savings on, please let us know. We will develop episodes in those areas that you can then participate in the future. We're not going to be able to do it by ourselves, so we'll need your help to, say these are the codes that should trigger an episode, and these are costs that are includable, and these are costs that are not includable. So the good news, bad news answer is, we're happy to partner with you, but the bad news is we'll need your help, and to do so.
Dr. Giblin,
Gene?
you want
Yeah,
to
Gene, can you hear me?
Yes.
I would have to completely agree with Dr. Richard. I don't know who talked to or what dermatologist you talked to, if any, about coming up with those episodes, but I completely agree with her. Those episodes are not very common in most, certainly outpatient dermatology offices, which make up the majority of dermatologists. And there are definitely other categories of diagnoses that would be much more appropriate for what we see commonly, and what, quite frankly, might lead to cost savings. I think she mentioned psoriasis, atopic dermatitis, skin cancer. There are numerous other diagnoses that would be much more appropriate. So it would seem to me that nobody talked to dermatologists about what possible episodes or diagnoses would be appropriate. But I clearly think that needs to be done, because the ones you have there right now, I think, are pretty much a waste of time, unfortunately.
So let me suggest this, that Dr. Giblin, you're in a large, for lack of a better term, I don't mean to be offensive when I say this, but hedge fund aggregated group. So what might make sense for you from a practical point of view, from a purely business point of view, is to have that group come in as an entity, and then they might have enough attribution to hit these 3 codes. And then you would get the advanced payment model bonus, which could be valuable to the group. So the other benefit of doing that would be that then you guys could kind of get used to it and understand how it works and be set up in it. And in the meantime, maybe we could have the Derm Society put a committee together and really look at the codes and suggest what could be added, like we did do with the emergency room docs, where we spent the last year meeting with them and kind of working out what they wanted included. Again, we're happy to do that. It's not a problem to do so. I don't know who at Change or Care First or whoever owned Prometheus before came up with these 3 codes, or how that happened. But really, it was just a matter of trying to include dermatology, and these were the 3 that were available. So I don't feel like slighted. It wasn't like
no, I understand that, but I would say, and I agree with you, for large groups like ours, I would still argue that even as large groups, primarily the vast majority being outpatient, none of those episodes apply to most of us on a regular basis. But I agree with you, as a group, I think the system seems to be set up for groups to apply and be an active part of this. And I agree with that. But I'll tell you honestly, I don't know if anyone talked to any practicing dermatologist before putting those codes in. It just seems pretty unbelievable to me that they came up with those codes.
My guess is they looked at it and said, oh, that involves skin. It must be dermatology.
Yes. So let me just be very clear. Literally, this is the first conversation that we've had with dermatologists. I think our commitment to you guys is, and I think Gene, asked us to talk with you guys. We pulled down any conditions that dealt with skin that are available for you guys to start, July 1st. I think we fully recognize that we, have not developed episodes that make the most sense for all specialty groups. But I think our commitment is to do exactly that. If you are interested in participating in a program where you could earn potential savings by creating efficiencies in managing either chronic conditions, in the performing services in the most efficient setting of care, et cetera.
Well, I have a very important question. You're nowhere in here did you talk about drug cost and where that factors into
Right.
the bucket of cost and cost efficiency and all of these metrics, because that's very not transparent in your presentation. And we'll take psoriasis as an example. The drug costs are absurd if you're talking biologics. So if you have there's no information in anything you've presented about how you're calculating the cost. I mean, these are chronic diseases that often require what are unfortunately expensive medications.
Right. So another good question. We include all Part A and B Medicare costs. So that will include drugs that are administered in a physician's office or in a hospital. We are not responsible and we are not able to include Part D prescription drugs. That's another, good news, bad news situation. Like, it's very hard to manage the cost of prescription drugs because pharmaceutical companies are crazy. On the other hand, there's potentially cost savings there. So Part D prescription drugs are not included. Part B drugs that are administered in a physician's office are potentially included.
So how would you figure out, we're going to take dermatitis as an example. How would you determine the cost of an episode of, we'll call it dermatitis or poison ivy, that you only saw them twice? Thus, it was cheaper than if someone had to come in 4 times. I mean, then I don't understand, if you're not calculating drugs into the cost, then you're purely talking about primarily E&M codes with, for example, if we're going to talk dermatitis, because you don't really do procedures, so there's no CPT codes per se. So how are you calculating cost?
So there's two, I'm going to give the general answer and then I can give a specific answer. So in general, your costs, or the costs that we would attribute to a participating practice, are the costs that occurred in the baseline period for those episodes. So if it's dermatitis, we would look at, what were your costs in 2020, right? And we would inflate them forward. It would be the average.
What are you using? What are these costs? What are you summing up? You're not articulating.
So it varies based on the different episodes. So we use a definition of related costs to the episode. Each different episode has a list of costs that are considered related costs for that. We can send you the list if you're interested specifically in
I just would like this in English. I'm sorry, I'm just getting frustrated. It's hard for me to understand. You keep saying costs, but if I see someone twice for poison ivy, and then we're calling that dermatitis, that's 2 office visits. So,
right. So I think, with your specific example, if on average in the baseline period, so in 2020, you saw people for dermatitis 4 times, and through, improvements in care management, et cetera, we're able to lower that to 3 times in the performance period, that would likely result in savings for you.
And maybe a better way to think of it, Dr. Richard, would be if the patient, if in some number of these patients, they end up in an emergency room or an urgent care, and because your office is more responsive, or you do a better job making sure they get appropriately treated, they don't end up in there, that can save significant costs and the outcome, particularly if they end up in an emergency room in Maryland.
Then how does it get credited to me?
Because what happens is that there is a target price that is calculated based on what was performed in the past, the baseline year. Then if you beat that target price because you're paying attention and being more efficient around a bundle payment, and you've managed a little better, you have your staff returning the phone call, you keep them out of the urgent care and the emergency room, and you get that cost down, then there's a shared savings calculation, as Jessica went over at the end. I think the point you made about these not being the best codes to do that, I mean, you can see this a lot better on the orthopedic side with a knee replacement. If you take a knee replacement and you move it out of the hospital and do it in an AmSurg center, and you have a higher quality and a better outcome, and you can see where there's real savings there. I see your point. If we could figure out a way to decide what dermatology codes it would make most sense to do this with, it makes a lot of sense. I would argue that I do think it makes sense for you guys to pick a couple practices, maybe some bigger ones, to do this, just to kind of understand how it works, So then we can work together and figure out what are the codes to put in. The nice thing about the way it's set up is there's no risk. It's a federal AAPM, so you get the bonus. If the federal government continues the APM bonus, it's the 5-point bump on MACRA. If they don't continue it, which is very likely, honestly, you get the increased MIPS score payment. So there's upside just for participating, and it's totally voluntary, and there's no downside. You only get the upside, you know, on the shared savings. So I think there's a lot of logic in working through this now. My fear is if we don't have physician involvement, putting on my MedChi hat now, and we don't work with the government and payers on this stuff, they're going to develop programs that are anti-physician or non-voluntary and then use their bargaining power to force us into them. So I think it's a lot better for us to kind of try to work with them and mold them. And, you know, this is the beginning for you guys. You know, we've been working with orthopods and GI guys for 2 and 3 years now. So you're kind of on the cutting edge for dermatology. And that's really what we're doing here. So that's the theory. And we need folks like you to kind of take leadership and help us move things in the right direction. This is too much for everybody at 9:40 at night.
So Gene, so what are our next steps? I mean, obviously we'd like to get some groups interested. So what?
So why don't we? Well, I don't know if we, look. I guess we don't need to get groups interested. It's okay if there's no interest. That's okay. It's not a problem.
Right.
We're not going to be offended or upset. What we want to do is, I think we'd like to get feedback on what we can do to make things better moving forward. So I will download the video and get it up on the MedChi website as well as the slides. Why don't we send them out to the other members of the Dermatology Society, and I'll send it out to the MedChi members who are dermatologists. Why don't we get more comments? If any of you are interested or thinking about doing this, because there is some upside to doing it. But you do get this benefit of being in an advanced payment model in Medicare, which is huge. It's really huge for the docs who did it this year. It worked out really well for them, but it's still a good deal going forward because it's a, what's the bonus on the MIPS score, Will? Is it 0.5? I think it's a 0.5, isn't it? Yeah.
I don't recall the.
I don't recall, but I believe that's the case. But it's an increased payment on your Medicare payments in a future year. So there's value in participating and trying to do this. And again, the private payers are going to be pushing these types of programs. So understanding how they work and what makes sense is good for your practice. I think this is what the future is going to look like, and we want it to be physician driven, not payer driven. So maybe you can put a little subcommittee together and come up with some suggestions on what code should be included or how we do this right.
Gene, I might mention if you could send some now to the Washington, D.C. Dermatology Society, that would also be a good thing to do, I think.
And maybe Dr. Giblin too, you can connect me with somebody on the business side of your group, if you don't mind.
I will do that.
There's another big player as well, I believe. Maybe someone can help us connect us up with them as well.
Yep, I'll do that.
I can talk to Dr. Singh, who's the president for the DC Society, about getting information out.
I think we have another question.
Hi, yeah. So if we do, get some information out to our society members, and there seems to be some interest and, potentially even enough interest to form a committee that wants to get together and maybe look at some potential diagnoses to include. I maybe missed this during the presentation, but is there some place where we can find like what the cost is that we'd be comparing to, like things that we think we could save costs and increase quality? Because we do a lot of things that are, like Dr. Richards, that are very expensive because the drugs are very expensive. We do things, for example, I'm a Mohs surgeon. We do Mohs surgery, which is very expensive, but it may be cost saving compared to like the average basal cell done by the plastic surgeon under general anesthesia. If we had some idea like what we could compare to, it might give us an idea like what diagnoses to compare to. Is there a place that we can find that data?
Yeah, so we will be happy to provide that data to you. So if you make a request, we can say this is, the costs that were included, and break them out by different cost type. Let me just try and clarify something. I think we need to know two things from you guys if we were to develop a specific episode. The first is what costs, or sorry, what procedures trigger the episode. And then the second is what costs are you consider manageable. And so one of the things that we don't want to do, for instance, is hold you guys accountable for, a car accident that occurs the day after the procedure that's going to be unrelated and is not manageable. So we'd be, the reason why I can't tell you like these costs are included is that it's partially up to you guys, right? You can say, we are going to be accountable for, X, Y, and Z costs that happen within the next 30 days, but we don't want to be accountable for, car accident costs, et cetera. But we can provide you data if you say, these are the codes that we think should trigger an episode. We'll tell you the costs, that occur in the 30, 90 days after that procedure, and a breakout by different cost types.
And I think one just quick thing that might be helpful is I can drop a link in what's called the EQIP episode playbook. Granted, this will only have episodes in the current year, but it might help sort of conceptualize, like when we keep saying relevant costs, like I understand this, like, well, what do you mean by that? It gives at least an example of, some of the ortho cases of sort of what is lumped into that beyond like E&M codes and things like that. Like I said, it probably doesn't apply to you, but if you're thinking about developing something new, it maybe will give a framework to help sort of understand how the episodes are sort of built. So I can drop that link in there, and it just shows what's available for this current performance year.
And with regards to the subcommittee, MedCai would be very happy to help. We can, and we can connect you with the right people to answer questions, whether it be someone at CRISP or HSCRC. So if you guys want to go that route and kind of get organized, Russ and I are more than happy to help you out with that. All right, anything else?
No, thank you, everyone, for a good presentation.
Yeah, thank you so much, Jean, Will, and Jessica. That was excellent. I think we have a lot of work to do, and I'll be happy to talk to Russ and Rachel and Zane, and we'll try to figure out how to move forward. I know it's late. Everybody needs to get to bed early morning tomorrow. So thank you for everybody who participated.
Thank you, everyone.
Thanks, everyone.
Thank you, everyone. Thank you.
Take care.